Welcome to the Lab Medicine and Pathology Grand Round. Today it's my pleasure to introduce our speaker, Dr. MMielke from Mayo Clinic. So Dr. MMielke received a Bachelor of Science in Neuroscience at the University of Pittsburgh and doctor degree in Epidemiology from the Johns Hopkins University Bloomberg School of Public Health. She's currently a professor in the Department of Epidemiology and a professor in the Department of Neurology at the Mayo Clinic in Rochester, Minnesota. Dr. MMielke works as a translational epidemiologist to further understanding of the etiology and epidemiology of neurodegenerative diseases. A primary focus of her research is the identification of fluid biomarkers for the diagnosis, prediction, and progression of Alzheimer's disease and other neurological diseases. She directs the Mayo Clinic Specialized Center of Research Excellence on Sex Differences with a special focus on abrupt endocrine disruption, accelerated aging, and AD. So she's PI of several NIH and foundation funded grants and published over 200 manuscripts. So today that she's going to tell us about developing biofluid-based biomarkers for operationalize the new AD research framework. Thank you, Michelle, for coming.
So thank you very much, Danny. So I'm really excited to be here today, and as I go through, if there's any burning questions, please feel free to jump up and ask them. How many people here are familiar or have heard of the new Alzheimer's disease research framework? So a few, okay. So I'm going to start, first, these are my disclosures. Come up for a second. I'm going to start out the talk just giving an overview and some background as to what the NIA-AA research framework is. And then I'll start talking more about the challenges of incorporating biofluid-based biomarkers into this network, and then finally identifying and integrating other fluid markers, so of work that's being done in the field as well as some work that we're doing down at Mayo. So historically, Alzheimer's disease has been defined as a clinical pathological entity. The first real criteria, diagnostic criteria, came out in 1984, led by first author was Guy McCann, also known as the NIN-CDS-ADRDA criteria, which don't say that 10 times fast. And with that criteria, you could only diagnose definite Alzheimer's disease at autopsy. So clinically, when you saw individuals, you could identify or diagnose people as either possible or probable Alzheimer's disease. And since that time frame, the distinction between neuropathological changes and clinical symptoms have often blurred. So if you look in the literature a lot of times and you're reading papers on Alzheimer's disease will refer to the clinical syndrome, Alzheimer's disease dementia, and then in other papers, Alzheimer's disease will be referring to the actual pathology. So the problem with this definition on a biological basis is that a syndrome is a clinical consequence and not an etiology. Using a biological definition could provide greater understanding of the underlying mechanisms. And so the general idea is, particularly if you're looking at mechanistic pathways in humans, if you're looking at clinical trials and need to enroll those individuals that are amyloid positive, it's important to have that biomarker knowledge. Also, in terms of incorporating a preclinical phase. And so we're now looking at preclinical Alzheimer's disease, people that are cognitively unimpaired, but have elevated amyloid in their brain. And by using biomarkers to identify that, potentially down the road, we can therefore determine who we should intervene if a therapy becomes available. Historically, another problem with defining dementia is just that we didn't have the tools to look in vivo. And so really in the past 10 years, with the introduction of amyloid PET, tau PET, variety of CSF markers, we can now start looking at AD and define it biologically in vivo in humans. So as a result of this, in 2011, the National Institute of Aging and Alzheimer's Association, the NIAAA, came up with the first research framework for Alzheimer's disease. And this had two important components that differed from the previous framework. First, they had separate diagnostic entities for preclinical Alzheimer's disease, MCI, and Alzheimer's dementia. This was the first time that preclinical AD was incorporated, but notably preclinical AD specifically for research framework. So MCI and AD definitions could be used more clinically, preclinical AD still pure research framework. And it was also the first time that they actually incorporated biomarkers, including amyloid and neurodegeneration in some of these definitions. Now, the biomarkers were not at all required, but helped to bring about the discussion in terms of some of the biological mechanisms. Since that time, and particularly really in the past 5 years, there's been a lot of research now with tau PET, the greater availability of amyloid PET, greater understanding of Alzheimer's disease mechanism, and so there's been a need to really update these diagnostic criteria. So earlier this year, there was another meeting where, again, supported by the National Institute of Aging and Alzheimer's Association, where they developed a improved, what they call, research framework, which really focused on a biological definition of Alzheimer's disease. And if anybody's looking in the literature, this NIAAA research framework is also often called the ATN criteria, and I'll get to that in a second. So the objective of this new research framework with the biological definition was twofold. One, to update a scheme for better defining, but also staging the disease across its entire spectrum, and also to make more of a common language. So again, when we're talking about Alzheimer's disease, are we referring to pathology? Are we referring to the clinical symptoms? To better try and define that. This is a research framework. It's not intended for general clinical care. In fact, there's a lot of studies that were recently funded, including a renewal with the Mayo Clinic study of aging, where, great, there's this research framework, but how does it really look? How does it operationalize? And so there's several studies ongoing now to try and test this and see what needs to be improved. This research framework is meant to be used for both observational, but particularly interventional studies, especially if you're looking at something like an amyloid therapy or where you need confirmation of a biological phenomenon. Now, there's been a lot of pushback in terms of the framework, and I'm happy to talk about that at the end, or if there's any questions, but one of the concerns is that with this research framework, as it's come out, that this means that all epidemiological studies or all studies where you're looking at Alzheimer's disease will require biomarkers. And that's not the case. I mean, there's clearly a lot of studies in which you're interested in cognition, don't necessarily need to know whether somebody's amyloid positive or tau positive. So again, it's more for mechanistic studies. This new framework has a definition of the Alzheimer's spectrum, including Alzheimer's pathological change, which is defined as presence of amyloid beta pathology. Alzheimer's disease is biomarker evidence of both amyloid and tau. And for both the clinical and biological spectrum with this new framework, it's defined on a continuum, which I'll show you in a second. So this is where the ATN criteria comes in. So as part of this framework, again, I mentioned Alzheimer's pathological change, you have to have elevated amyloid pathology. And this can be either through CSF, amyloid beta 42, 42-40 ratio, or amyloid PET. For Alzheimer's disease biological definition, you have to have evidence of both amyloid and tau pathology. Now tau, this is the aggregated 3R, 4R tau, which could be defined either through CSF phosphorylated tau or tau PET. And then the third N criteria is in brackets because this is non-specific to Alzheimer's disease, but as neurodegeneration is, but is thought to contribute to the staging and severity, especially when you're looking at clinical disease. And so the proposal then was to define this using CSF total tau, structural MRI, or FDG PET. So if you look at, if we're looking at the 3 potential biomarkers, A, T, N, there's 8 different profiles that could, of course, result from this. So individuals that are thought that are negative for A, T, and N, of course, have normal AD biomarkers. Individuals that are amyloid positive or the Alzheimer's continuum, again, those only amyloid positive, tau negative, Alzheimer's pathological change, those amyloid and tau positive Alzheimer's disease, and amyloid positive, neurodegeneration positive, but tau negative, suspected non-Alzheimer's pathological change. And then those that are negative for amyloid, of course, are on the non-AD pathway, since amyloid is a necessary component of biological Alzheimer's diagnosis. Now, I talked about a continuum in terms of clinical. So the viewpoint then is that you can potentially use this biomarker profile throughout the cognitive staging of dementia. So whether you're cognitively unimpaired, have MCI, or have Alzheimer's disease dementia. So what are some of the challenges? As I highlighted with the ATN framework, each of these components include a CSF marker. So A, again, elevated amyloid, T, elevated phospho-tau, and then N, elevated CSF total tau. But these, again, are suggestions, and so in terms of operationalizing these for research purposes, there are a lot of challenges. So next I'm going to go through just a few of the challenges in terms of thinking about how to operationalize these criteria. So one that's probably very obvious is the potential discordance between CSF and neuroimaging. So a lot of research studies out there, you have imaging or you have CSF, and you don't often have both. Some have both and they don't agree. And this is not, although you oftentimes think that CSF and neuroimaging measures should agree, they're actually measuring different things. That's not really often discussed in the context of the biomarkers. So CSF markers are measures of protein concentrations from the lumbar sac that reflect the rate of production and clearance at a specific point in time. In contrast, neuroimaging measures are generally the magnitude of the neuropathological load or the accumulation over time. And so what this means is that CSF measures are more time-dependent measures of pathological states, and that PET measures, amyloid PET, tau PET measures, are cumulative measures of the pathological load. And a great example showing the difference between these two is the correlation with age. And so in our studies, when you look at tau or amyloid and even tau PET, there's a definite increase with age, very significant, increased amyloid burden among individuals. The frequency of amyloid positivity increases with age. However, when you look at CSF amyloid, there really is no association with age. And this, again, is because it's not a cumulative measure of pathology, but that it is an ongoing state-based measure. There are several studies in the past that have compared both CSF amyloid and amyloid PET. And this is just an example by Schindler that was recently published. So with CSF amyloid, of course, low CSF amyloid is indicative of elevated brain amyloid. Whereas with PID PET or amyloid PET, high levels are indicative of brain amyloid. And so by looking at it diagnostically, these individuals here that are low CSF A beta and high amyloid PET are the individuals that are certainly A positive. These are the A negative individuals. And when you look at this, there is a pretty good correlation and pretty good consistency between both of these. But there are also a lot of outliers. There are a few people that are amyloid positive based on amyloid PET, but not on CSF. But there's quite a lot of people that are amyloid positive based on CSF, but not on amyloid PET. And there's been a lot of discussion going back and forth as to why this might be. And one of the theories that has been looked at longitudinally is that CSF levels may change earlier than amyloid PET. So it might be an earlier marker of preclinical AD. There are less studies right now that have started to look at CSF phospho-tau and tau PET. However, there is some discordance there as well. if you look at the general correlation, looks pretty good. But when we start thinking of diagnostic measures, we have a few outliers. So this middle frame right here is CSF phospho-tau. And then on the bottom, we have, using the T807 tau PET ligand, total cortical tau PET SUVR, entorhinal tau PET SUVR, and then the inferior temporal lobe. And although in general, again, there's a decent correlation, we've got some outliers. So with cortical tau PET, we've got these people that are high on tau PET but low on CSF p-tau. Looking at entorhinal, high on CSF p-tau and low on tau PET. And so again, it raises the question of what we're going to do in this in terms of defining people that are positive for A and for T. So there's a lot of open questions and possibilities, and this really hasn't been thought of in terms of the framework yet. So for example, should one medium, if both mediums are available, CSF and imaging, should one be prioritized over the other? And we might think that maybe in preclinical AD, if CSF is changing earlier, that CSF may be prioritized over imaging. Yes?
I have a question related to the A-beta-42 and the amyloid imaging. You said that A-beta-42 going down may be an earlier sign than the amyloid imaging. The amyloid imaging goes up with age, and A-beta-42 doesn't necessarily change.
That's true, but again, amyloid, so it's a different measure. So, but time dependently, you're still measuring amyloid beta metabolism in the brain. So regardless of age, if you're looking at, this is all at one point in time. And so the accumulation hasn't necessarily happened yet in the brain for those people, or significant accumulation to cross the threshold for those people with the amyloid PET. But there's still, the clearance and metabolism of amyloid is already changing and can be detected through CSF. Does that make sense? No.
Well, it sounds like not everybody with high amyloid in their brain has CSF indices of Alzheimer's disease.
No. So generally, everybody that has high elevated amyloid in their brain is going to have low CSF amyloid beta. That's pretty, as I, when you look back at this, there's very, very few people that have elevated amyloid PET but do not have low CSF amyloid. But there's a lot of people that have low CSF amyloid but don't have elevated amyloid PET yet based on our thresholds. And so that might mean that the changes that you observe in terms of CSF metabolism, CSF clearance might happen a little bit earlier than the actual plaque deposition in the brain. And so that's why it's thought that CSF amyloid beta might be a little bit earlier marker. So if we're thinking about preclinical Alzheimer's disease or among a group of cognitively unimpaired individuals, maybe CSF is going to be a better marker. So if you have the possibility in a research study of both, one possibility is to focus on CSF first. A second possibility, if you have both, is to look at the combination of positive. So those that are positive on both amyloid PET as well as CSF PET maybe have a score of 2 and are more severe compared to those with 1 and those with 0. Another problem with the current use of CSF markers is standardization. And so there's some groups that are using CSF amyloid beta 42. There's some groups that are using the 42 to 40 ratio, and there needs to be more of a consensus in terms of which might be better. And then lastly, as we're trying to compare CSF and tau PET or amyloid PET, there are of course different tracers. With tau PET, I think we're, I don't know, up to maybe 5 different tracers, and they look to give you slightly different information. And so as we think about this comparison down the road, we're going to ultimately have to decide which tracers that we want to focus on. So a second challenge is the determination of cut points. So the ATN framework does not talk about cut points. It talks about somebody being amyloid positive, tau positive, neurodegeneration positive, but that's it. And so it's left up to the research community to try and identify these. And it's very possible that multiple may exist depending on your use criteria. So if you're looking at incorporating this framework in terms of screening the population, you might have a more lenient cut point as opposed to if you're looking for actual diagnosis, in which case you might want a more conservative cut point. Again, this will affect both the sensitivity and specificity, depending on what cut point you use. And then the question also is, what is the gold standard? And this is something that we're working on at Mayo right now, in terms of defining a cut point, let's say, for CSF amyloid beta. Do we compare it to young normal individuals? Do we compare it to diseased individuals? Do we compare it to autopsy-confirmed individuals? Depending on who you compare it to, the cut point differs a little bit. And so as a community research, we need to identify which ones might be best and all do it in a similar fashion. Another challenge in the cut points is just the assay reliability across platforms. So this has uniformly been a problem, especially for CSF. There are now more measures, the Roche Alexis measures and a couple others that have lower variability that are looking more promising. But a problem if people are using the same platform in different labs and even different platforms. Another thing with cut points is that most of the work, especially with CSF, has been done on clinical samples. And that becomes problematic when we're trying to generalize to the population and think about how this could be used for clinical use down the road. Many of these clinical samples don't significantly vary by age, sex, ApoE4 genotype, and who you see in the clinic sample is going to be different than the general population. And so as we think about cut points, we really need to incorporate samples from the general population to see really how it looks. Ultimately, if we want to find a screening measure, it's going to be used in the population. It's not going to be specific for these clinical samples. There's many considerations for pre-analytical variables that could affect the cut points and could affect the levels. Some of these are more important for CSF, and some of them are more important for amyloid. For example, the time of day seems to be more important for CSF. Of course, plasma versus serum is a key component for blood-based markers. And as we go forward in terms of thinking of the pre-analytical variables, I mean, ideally we want to start with an optimized protocol to get everybody on the same page, but ultimately, again, we're going to have to translate this to the real world. And so consider what's going to be available from a population-based perspective. A third challenge is distinguishing between CSF p-tau and t-tau. As I mentioned, CSF p-tau, which is typically p-tau 181, has been defined as T, and CSF t-tau has been defined as N. Now, the background behind this is because CSF p-tau is thought to be specific for Alzheimer's disease. In contrast, CSF t-tau is thought to be more of a non-specific neurodegenerative marker. So if you look at both p-tau and t-tau are elevated in Alzheimer's disease, but t-tau and not p-tau are elevated in Creutzfeldt-Jakob disease, traumatic brain injury, stroke, and a couple other neurodegenerative disorders. And so this is why they separated CSF p-tau and t-tau. Now, the problem with this, though, is that when we look in the CSF, there's actually a very high correlation between the two. These are a bunch of different studies, and then what we've seen in the Mayo Clinic study of aging. And so down here is the correlation between CSF t-tau and p-tau. So 0.98, that's extremely strongly correlated. Both p-tau and t-tau are also very similarly correlated with CSF amyloid beta. And so then the question becomes, well, is CSF p-tau specific for Alzheimer's disease? And what should we do for CSF t-tau? Do we keep CSF t-tau as a measure of N? Is there a better measure out there? And is there really any benefit of including t-tau within the ATN framework? So this is where, next I'm going to talk about identifying and integrating other fluid markers. The original ATN criteria, or NIA-AA framework, was based on the available research and technology. And this was actually written a couple years ago. It was published earlier part of this year. There was an extended period for people to comment on it, which delayed the publication. And within the past couple of years, in terms of fluid-based biomarkers, there's been just an explosion in terms of new techniques as well as new data that are coming out. So again, this was the current state as of a couple of years ago, but the research framework was written to expand and incorporate new markers as they were identified. The research framework did not originally include blood-based biomarkers, but now with new technology, that's also a possibility. So next I'm going to talk about different possibilities, especially blood-based biomarkers that we can potentially incorporate into the ATN criteria. So the first is plasma amyloid beta 42, or the 42 to 40 ratio. Now, again, from a screening mechanism, if one of these amyloid therapeutics end up becoming or being shown to be effective, there's going to be a need to screen at the general population. We can't screen people with CSF, and we can't screen people with neuroimaging. So there's a lot of effort right now being put into developing a plasma amyloid marker. And ultimately, you know, it's unlikely that a blood marker is going to be used for diagnosis, but probably as a triage to determine who's going to go on to more invasive and costly CSF and neuroimaging and who is not. Plasma amyloid beta has been looked at as a possible marker for a good 10 years. And the original studies published in JAMA Neurology, New England Journal of Medicine, were very mixed. Some found that high levels of plasma amyloid were associated with risk of Alzheimer's disease. Some found that low levels of amyloid were associated with risk. Some didn't find any association. And really the main problem with these is when you look at the papers, there was so much variability in these that, you know, on an individual level down the road, there's no way you could use it to predict who's going to develop Alzheimer's disease. But again, as I mentioned, in the past couple of years, with the new technologies and more sensitive measures now, there's some good evidence that we may be able to measure plasma amyloid beta. So last year, there were 2 papers that came out just within a few months of each other using mass spec-based methods. One was from Washington University, led by Ovid, and the other one was a collaboration between Japan, or a group in Japan, and the ABLE study in Australia. I think it's Australian Imaging, Behavior, and Lifestyle Study, or Biomarkers and Lifestyle Study. And essentially, both of these show that you could clearly differentiate, for the most part, those individuals who were amyloid negative and amyloid positive. In this case, at WashU, they looked at the 42 to 40 concentration. Down here is the amyloid beta. For whatever reason, they switched it up and looked at the 40 to 42 concentration, which is why the direction is reversed. But still, the AUCs under the curve were about 0.89 and very significant difference. So this is being looked at and trying to be replicated in several other studies. There are also many other platforms that are being looked at. These are just a list of some of the platforms. With mass spec, the Henrik Zetterberg and Kai Bleno in Sweden have developed another mass spec method, Simoa, MayQ, and various ELISA assays as well. So a big question in the field is, you know, what assays are going to be best? What will be more useful? Ultimately, we'll have to think of, you know, in terms of clinical use, the cost as well as the high throughput. Because again, if we need to screen individuals, mass spec may not be the best method. Right now, there is a couple round robins going on, so using the same samples and measuring it on all these various different platforms. Like I said, there's a couple more, and I can't remember what those platforms were. But that'll at least tell us and show us some of the different differential variability in plasma amyloid beta. And then we're also going to have to compare these among patients as well and see how it looks. So how about T? In the past, we and others have looked at plasma total tau and shown that it is associated with cognitive decline and does appear to be independent of brain amyloid beta. Again, phosphorylated tau is thought to be more specific to Alzheimer's disease. But the problem in the past is that the phospho-tau levels in the blood, plasma, are very low. And so it's been very difficult to try and to quantify the plasma tau measures. Recently, there have been a few studies that have shown the feasibility of doing this, but the variability has been quite high. So we had been working with Jeff Dage at Eli Lilly to look at plasma tau, total tau measures to start out with using the Simoa machine. And more recently, new antibodies that can measure plasma phospho-tau. These are antibodies that Lilly created, and they are now starting to make available for academic facilities to use as well. So we conducted a study looking at both plasma t-tau and p-tau, and wanted to compare the two both across the AD clinical spectrum, and then in relation to brain amyloid PET, tau PET, and cortical thickness, and then as a possible screening marker for brain amyloid. And I'll talk about that and why we chose p-tau and brain amyloid in a couple minutes. Our hypothesis was that plasma p-tau 181 would be a more precise marker of Alzheimer's disease pathophysiology measured in vivo compared to plasma total tau. And so what we found, in this middle row is plasma phospho-tau, and here's plasma total tau. And we find that plasma t-tau is significantly associated with elevated amyloid PET and elevated amyloid, and elevated tau PET. In contrast, total tau was only associated with cortical thickness. And it's interesting as we look across the clinical spectrum, so cognitively normal, MCI, and Alzheimer's disease, that our strongest correlations among cognitively unimpaired between p-tau is with amyloid. Then we get into MCI and we see correlations with both amyloid and tau, and then in Alzheimer's disease, again, we see that association. So next we wanted to determine whether the associations between plasma phospho-tau and t-tau depended on whether you were amyloid positive or not. So again, this will help to determine whether it's associated with the AD pathophysiological pathway or whether it's more of a non-specific neurodegenerative marker. And again, what we saw with p-tau was that plasma phospho-tau was associated, more highly associated with tau PET and entorhinal cortex among those individuals that were amyloid positive compared to those that were amyloid negative. So both with the cognitively unimpaired as well as with the MCI. We did not see that strong of an association among the AD group. However, the entorhinal cortex is one of the first areas that are affected. And so our hypothesis with that is just that that area was saturated and there's really not that much variability. When we look at other tau PET areas that aren't as early affected, then you do see those associations in the AD group as well. In contrast, again, total tau, not really associated or stronger among those that were amyloid positive, and if anything was more strongly associated with tau PET among those that were amyloid negative. Lastly, we looked at the predictive accuracy of plasma p-tau 181 and total tau for elevated amyloid PET. And the reason we chose to look at amyloid PET was because at the time, our tau PET was new. We were trying to establish what the cut points should be and exactly what regions of interest we should use. This was trying to understand and find a risk score for amyloid PET was something that I had been working on for about 1.5 years prior to this. As an epidemiologist, again, can we figure out a way to screen the population using easily accessible variables? And after 1.5 years, the only things I found were age and ApoE. It didn't matter, even looking at cognitive tests, looking at comorbidities, looking at other factors, that was the only thing that appeared to be associated with elevated amyloid. So, when we think about a risk score and we want to find a factor that can be used for screening for elevated amyloid, really we should compare it to age and ApoE. Because if it's not better than age and ApoE, then there's really no point in incorporating it. So again, here we looked at the predictive accuracy of plasma p-tau and t-tau for elevated amyloid PET among non-demented, cognitively unimpaired only, and then MCI participants only. And what we found was that plasma p-tau was as good or better than age and ApoE, as well as the combination of age and ApoE. So then the question came up where, okay, what about if we stratify individuals by amyloid positive and amyloid negative? And when we stratify individuals, among those that are E4 negative, plasma phospho-tau is significantly better than age alone. And among E4 positive, plasma phospho-tau is also significantly better than age alone for E4 positive individuals. So again, this is telling us that plasma phospho-tau may actually be beneficial down the road in terms of screening for amyloid beta, and is an indicator, potential indicator of AD pathophysiology. Skip through that. So lastly, I'm going to talk about our N category, or neurodegeneration. And one of the big focuses in the field lately has been on the neurofilament light protein. Neurofilament light is thought to be a nonspecific marker of neuronal degeneration, particularly in the large subcortical axons. You also have some measure in the cortical axons, but it's supposed to be mostly affected by subcortical axons. It's been looked at in a variety of neurodegenerative diseases and found to be elevated the highest in those that are the most rapidly progressive. So ALS, MS, FTD, Alzheimer's, stroke, TBI. There was just a paper that came out this week in JAMA Neurology where they also looked at this in Parkinson's disease, Lewy body dementia, and across a variety of dementias. And they seem to be elevated in all dementias. Now again, those that are the most fast or rapidly progressing, NFL seems to be elevated the highest. So this has brought up the question as to whether CSF neurofilament may be a potential marker of neurodegeneration and a better measure than total tau. The initial work of this, looking at CSF neurofilament, was conducted in the ADME study, and they found that the highest levels of, highest quartiles of NFL was associated with greater cognitive decline, greater increases in white matter hyperintensity, and also greater degree of brain atrophy over up to 4 years. We recently published a paper taking a step back and looking to determine whether NFL could be prognostic among those individuals that were cognitively unimpaired. And here we did find that NFL, high levels of NFL, was associated with risk of MCI. And when we look at quartiles, the highest quartile compared to the lowest quartile was associated with a threefold risk of MCI. And this was over an average of about 4 years of follow-up. An important component of the study for us, though, was not only to look at NFL as a prognostic marker, but also to compare it to t-tau. So since t-tau right now has been defined as our neurodegenerative measure for the N criteria. And what we found, at least among cognitively impaired to MCI transition, total tau did not at all predict who is going to develop MCI. And so to us, this indicates that plasma or CSF NFL is a better marker of disease progression than CSF total tau is. Now, the one thing that's been really exciting about NFL is the correlation between both plasma and CSF NFL. So a lot of times you don't see all that great correlations between peripheral and CSF markers. This is the graph that is typically shown if you go to neurology meetings, showing the correlation between CSF NFL and blood NFL with a correlation coefficient of 0.89. Now, it's a little bit misleading because this is actually among HIV dementia patients, but when we look in our cohort, as well as within the ADNI cohort, the correlation coefficient is still about 0.56, 0.6. So that's still quite a lot stronger than the majority of blood CSF correlations. So with this strong correlation, it's led to the question of whether plasma NFL could potentially be used as a potential marker of neurodegeneration. And the first studies, again, that came out were from ADNI. They looked at it at one point in time, or at the baseline of ADNI, and found that higher levels of NFL were associated with about 4-year cognitive decline, as well as cortical atrophy and cortical thickness decline. We presented some data at AAIC and now have conducted some more analysis and recently submitted this paper. But there have been no studies that have really compared CSF and plasma NFL in terms of progression. So the aims of our study were twofold. One, we wanted to look at and compare these two markers and determine if one is, for example, we figured that CSF might be more prognostic and a better marker than NFL. And then secondly, the majority of studies to date have only looked at NFL at one point in time. And so we don't know how change in NFL, either from plasma or CSF, is associated with change in cognition or if it tracks with neurodegeneration. This study was done with our Mayo Clinic study of aging. We had to put our renewal application in. And so we did some pilot analysis, and so we only have 79 individuals in this study. All 79 had baseline CSF and plasma NFL, and they all had a repeat neuroimaging scan at 15 or 30 months. And then with plasma NFL, we had it both at baseline and the follow-up visit corresponding with neuroimaging. So this first graph is just comparing baseline plasma NFL and CSF NFL for change in hippocampal volume, cortical thickness, amyloid PET, FDG PET, corpus callosum fractional anisotropy, and then a variety of global and domain-specific cognitive decline. The blue is plasma NFL, and the red is CSF NFL. This dotted line indicates 0, so if it's less than 0, this means that elevated NFL is associated with reduced hippocampal volume. And as you can see, as you compare the blue and red, I mean, they're really quite close. And if anything, we ended up finding that the estimates for plasma NFL were a little bit better than those for CSF NFL. Even when we restricted it to cognitively unimpaired individuals, so there were 15 that were MCI and the rest were cognitively unimpaired, we still found the same association. And then the vast majority, I think 70 of the 79, had 30-month follow-ups, whereas the others had 15-month follow-ups. And when we restricted to 30-month follow-up, we also saw the same thing. So this may suggest that plasma NFL is as good as CSF NFL in terms of predicting progression. Lastly, as I mentioned, in terms of serial samples, we also looked to determine whether the change in plasma NFL was associated with change in markers of neurodegeneration and cognitive decline over a short period of time. So again, given that this was 15 to 30 months, we weren't actually expecting a whole lot, but we did find, even in the small sample size, that increasing NFL, meaning more neurodegeneration, was significantly associated with declining attention, global cognition, trends for memory and language, and then there were also borderline trends for hippocampal volume and cortical thickness. We did see an association with amyloid PET, and for the life of me, I can't explain this, because in all of our other work, we've shown that the association between NFL and cognition is completely independent of amyloid. So NFL seems to be prognostic among those that are amyloid positive and those that are amyloid negative. But data is data, and we need to present it. So maybe it's those that are amyloid positive or showing amyloid accumulation are progressing the fastest, but we'll have to see and replicate that. So just in terms of conclusion again, the ATM biomarker profile, I think these results suggest that there's a lot of possibilities to evolve this research framework. So again, with A, potentially down the road incorporating plasma amyloid, with T, incorporating plasma p-tau, and then with N, incorporating plasma or CSF or plasma NFL. And I'm guessing that the CSF total tau is going to go away from this framework. One thing we haven't done, so I just mentioned briefly in terms of plasma total tau, which does seem to be a marker of neurodegeneration. We have not compared plasma total tau and plasma NFL yet. So that's something we're planning on doing in the MCSA renewal to see which might be better in terms of predicting neurodegeneration and also tracking with the degeneration. So, and then down the road too, the research framework left open the idea of incorporating other pathologies. So, you know, hopefully, we currently don't have any way to measure alpha-synuclein, either imaging, CSF, blood-based measures, but ideally that would be important down the road if we had a marker, as well as TDP-43, vascular and inflammation. So the long-term idea of this is that at some point you'll have measures for all of these and then be able to determine what track people are on, how fast they're progressing, and what therapies they might most benefit from. So in conclusion, the ATN research framework provides a biological definition of Alzheimer's disease using imaging or CSF biomarkers. So different from the previous framework in terms of trying to separate the clinical and biological definitions. As I've highlighted, you know, this was put out there. There are several challenges in terms of actually operationalizing their criteria and things that we need to work on. But I think this gives us a good basis in terms of thinking how to go forward, and as well as trying to understand what some of the mechanisms are. It's a really fun time to be involved in the biofluid research because there's so much happening. There's so much new technology that's coming out that, you know, I do think within the next 5 years we'll have a blood measure. Whether that will be useful for clinic yet, not quite sure, but I think we'll have something that we'll be incorporating into at least research studies in the next few years. So I'd like to acknowledge a lot of my collaborators, both at Mayo Clinic and in Gothenburg, Sweden, and I'm happy to take questions.
That was a very interesting talk. Thank you very much. My guess is that autopsy is still the gold standard for this. And the question I want to ask you is, are you able to get autopsies on many of your subjects? And what do you do in the protocol to try to assure autopsies?
So in the Mayo Clinic Study of Aging and also our Alzheimer's Disease Research Center, which are two kind of separate entities, we ask everybody if they will participate in autopsy. We try and we have a higher percent that agree in the Alzheimer's Disease Research Center, because generally those that are included there have Alzheimer's disease, or we also have a specific focus in our ADRC on FTD and DLB. In our population, we have about 20% that will ultimately agree to autopsy. So since we're seeing 3,000 people every 15 months, eventually this will add up, but it takes a while. You know, one thing that we've faced with, so our Alzheimer's Disease Research Center actually is split between Mayo Jacksonville and Mayo Rochester. And one of the reasons for this is, you know, well, with different expertise, the neuroscience department is down at Jacksonville, but there's also, of course, more opportunities to include African Americans. And that has been, you know, even down there and trying and doing a lot of focus groups, it's still hard to get autopsies from African Americans. So, you know, we try and push education and things like that to inform more people, but kind of is what it is.
Over time with some of these clinical markers, the reason I ask is that
So that's definitely a problem in the field. As I mentioned with NFL, it's the same thing with amyloid beta and with tau, where for the most part people have measured it at one point in time, and we don't know serially what it looks like, how it changes over time, and how variable it is. And that's a critical component in terms of incorporating these going forward. In our renewal application, we have an aim where we are going to measure plasma amyloid beta, p-tau, t-tau, and NFL in 1,000 people at 3 different time points. So it's only about a 30-minute space since we have 15 minutes between clinical visits, but at least that'll start to give us an idea of how they change over time and how they change in relation to each other, which I think is also important. But that's a definite problem in the field. With CSF, of course, it seems like in Europe they can get serial CSFs on people, and in the US it's a lot harder. Of the CSF we have, I think we ask everybody, maybe a 10% response rate, and we do have one super user that has done 4 CSFs, but there's very, very few people that will do 2 or even 3.
Another kind of example we use is anything known about how over time when changes start?
So in terms of biological or clinical, or both?
Both. It's a question of how, is the process going on throughout their life, or is it just something that's
So the thought is several studies have published findings that suggest that amyloid accumulation will be about 15 to 20 years prior to the start of clinical symptoms. And so that seems to be, I mean, the span varies. Sometimes it's 10 years, sometimes it's 20 years, depending on the study. But it does seem to be earlier, which is why there's now this more focus on preclinical AD, even though it's for research purposes. I mean, we don't want to use it in the clinic. We can't do anything about it right now. And not everybody that has Alzheimer's in the brain ends up going on and developing clinical symptoms. But that's, and then in terms of tau, I think there's still a question. Tau is more closely related to the clinical symptoms, but ultimately neurodegeneration tracks the strongest with clinical symptoms. The retinal amyloid data? No, we haven't. There's, I can't remember the investigator. There's somebody in our group that is starting to look at that. And I'm not sure where that project is yet. I think you're doing some work here, right? Oh, that'd be really interesting.
Well, I have a question about, you showed the blood NFL is actually seems to be better than CSF NFL in predicting like changes in cognition and imaging. So what are your thoughts on the reasons that would
why that is? Yeah, that's something we scratched our head about quite a bit as well. It's not. It looks like it's better in terms of estimates. It's not statistically significant. But the other thing is that CSF NFL and plasma NFL were done using 2 different assays. So we Z-log transformed them so they could be comparable in terms of the estimates. But with plasma NFL, much more difficult, lower concentrations, and so the Simoa platform is used to measure plasma NFL, whereas more of an ELISA-based approach is used for the CSF NFL. So, I mean, it's possible that the levels are a little bit more compacted in plasma NFL versus CSF NFL. But again, we need to replicate this and look at that a little bit better.
Thank you, Michelle.